Hi, and welcome again to Myth Magic Medicine. This season is all about immigrant doctors coming to the US, and my guest today is Swapna.
Yep.
Swapna is all the way from Mumbai and found herself unexpectedly in the US. So, Swapna, please tell us about
Yes.
yourself.
Oh, no, absolutely. Thank you, first of all, for the opportunity, Denise. I mean, for me, this is really a great platform to talk about my experience, both as a doctor and as a person, human being.
Mhm.
Um, because coming from another country and trained in medicine in another country, and then redoing everything, especially reworking all the cultural aspects, that's a humongous game. But I am so blessed today after practicing 20, 25 years of psychiatry here and couple years in India, maybe one and a half year.
But and actually, if I could just interrupt the flow for
Yes,
a moment,
yeah,
psychiatry must have been one of the more difficult ones because culture is everything.
mhm.
So,
It is
I go back to your flow. I'm sorry, I didn't.
no. But you're so right because that's what I was going to actually sort of focus on the difference of how it was for me to practice psychiatry back then. Mind you, I'm talking about the 90s. I'm dating
Mhm.
myself here, but still, when I started psychiatry, I mean, there was a lot of objection, not even a lot of surprise from my co medical students, but also my dad, who is a general practitioner. I was hoping that I would do some traditional pathways, OBGYN or pediatrician, because there was something that entailed medicine there. Psychiatry was such an taboo subject or came up with so much stigma that they weren't even sure how I would practice in India, what I would really do, as if there
Mhm.
was no depression, psychosis, mania, none of that existed in that very uber Indian culture, wherein you never talked about such things, even as a doctor, even as a physician. So this for me was my impetus because I'm always challenging myself and I wanted to throw myself in a field where really there was no help. And I really felt that when I have practiced there and here, I feel like there's such a vast difference. One of the things that was very interesting for me was that we used to get from a lot of religious places because in India at that point in time, again in the 90s, now I know with rapid urbanization, global growth, everything is different. But at that point in time, a lot of the time, families brought their loved ones who were afflicted with, according to them, demons or ghosts or whatnot, because they were hearing voices, that we would actually get calls from these places. I used to work in a government hospital in India as a resident, and we would take referrals from them and then start patients on antipsychotics and watch them get better. So it was a unique referral system, nothing that I would ever see here. Um, but that was one of the biggest difference that people were marginalized. This was basically a fringe population that really had to be locked away. You don't have to look at them. There was no concept of the fact that mental illness exists, you know, ubiquitously. I mean, we lived in a part of a world where it was just denied that the 1% rate of schizophrenia would never occur. So this for me was a very interesting
Do you
thing.
do you think that was because people had not seen successful treatments,
Well,
and so it's sort of self-perpetuated?
absolutely. So couple things. I think in Southeast Asian populations, and I think this goes to a lot of countries where there is culture as a taboo in a way that you cannot speak about your feelings, how you're doing, what is depression, what is feeling sad. And a lot of the time the complaints process through somatic complaints, such as people would talk about having nausea, vomiting, or uneasiness. And this was repeated studies. They found that this was actually predominantly related to a psychiatric issue, a stress in their family. So this
But it was
concept,
an acceptable
it was
embodiment of this distress. Okay.
absolutely. You couldn't say that you were depressed. You couldn't say that you were not feeling a certain way, but you could say that you have extreme abdominal pain or you
Mhm.
had headache. There are a lot of culture-bound neurotic syndromes. For example, I mean, I think there is something called Kuru that exists, and there is running amok in different cultures. It's
Mhm.
given a name that is kind of like embedded in mysticism.
Mhm.
And there's a lot of neuroses that is seen in somatoform disorders. So schizophrenia, for instance, it was observed that there's a certain uniformity in the way schizophrenia presents, right, globally. But there are equally distinct cultural differences. But there is a reason for this. This is because it was interpreted as what was then thought to be related to the divine or related to possibly the devil. There is a term called jinn in certain Muslim regions. This is sort of like the influence of that. So a lot of people interpreted it that way, so that that was acceptable culturally to talk about it. There's many times when people would say, "Oh, I'm depressed." People would say, "What is that? Just spruce up, just kind of buck up."
That's unfortunately prevalent in many cultures, that attitude. Who, if it's all in your head, it can't be that important.
Oh, yes.
So
that is,
and
that
one of the banes of my life is I belong to the Royal Society of Medicine in the UK,
oh, yeah.
which is an international organization, really, but they have a section on hypnosis, which is my thing. But it's called Hypnosis and Psychosomatic Medicine.
Yes.
And everybody is insulted when you say something is psychosomatic. But we talk all the time about the mind-body connection, as if these are not the same two things. It's just infuriating.
And somehow I feel like, and this for me was an eye-opener, that even in the US, as you said, culturally it exists everywhere. Mind and body are so distinct. Even as we practice medicine here today, it's almost like we get referrals from other doctors, and there is a little certain amount of, this is not something I can deal with. Okay, that this person, they use the term crazy very flippantly, or this person is acting crazy. I mean, and I think that it is so insulting in so many ways to the, intricacies of what a human being is. I mean, how can you not expect somebody who's going through cancer to not have an emotional response to that?
Yeah, of course.
So why don't we treat our, or why don't we teach our medical students or residents to be more empathic, to look at it as a whole connection?
I almost feel like this is like, okay, this is going to be part 2, because we're really I don't want to talk to you about all of this, but I would love to know a little bit more chronologically when you came to this. You defied your family's expected pathway for a start, and you went into psychiatry. And you did a residency program there in
Yes, I did actually a year, and then I got actually married, an arranged marriage, but that didn't work. But then when I came here, I decided that I will use this opportunity.
So you came here because the arranged marriage, and again, I stress, because I do I interview a fair number of Indians. Arranged marriage doesn't mean forced marriage.
It's no. It wasn't forced. It was arranged.
But as will happen with many versions of marriage,
this
one didn't work out. But it was the reason that you came to the US. That wasn't on your
reason. I mean, I always did think that since my interest was in psychiatry, maybe my future lay abroad. Not necessarily US. I think I was looking at UK at that point in time. A lot of my colleagues were going to UK. But then, life happened, and I came here. And then I decided to use this as an opportunity to pursue. It was really difficult because to redo all the USMLE exams and to get
so long after training.
So long after training, I had to retrain, and then retrain culturally to know how to address patients who are from here and be aware about my own cultural experiences, my own cultural, barriers, and aware of my transferences, counter transferences. So I felt like the residency in US was a very interesting and a very growth kind of like the growth that I saw personally in me was immense. I realized that so many myths and so many concepts that I had about culture, about society, the way I was raised, and then I now see here, and the exact opposite of it in a very good way, and also the diversity that I saw here really led me to believe.
Of course, from here, there is no American. Oh, yes, there is. There is a predominant American culture, but there's all these subsets.
Yes,
because it's such a melting pot of places. So where you are now practicing, the Seattle area?
Yeah, so right now I'm in.
So how many cultural groups do you think you can quickly figure out? How do you have to change your practice?
Right. So so it is interesting that so you have to change your practice based upon where your patients, roots are from. Absolutely. So if I have a patient who is from India, there is that familiarity, there is that understanding, and there are certain nuances that are got on both sides. But let's say I have a patient from Eastern Europe, and it's a little
Yeah.
bit, I have to like immerse myself in what that upbringing was like. And there's language barrier, and sometimes there is culture barrier. But ultimately, what is really important? The human experience, it's the same.
Mhm.
Trauma is trauma, illness is illness, and humans are humans. And that transcends all cultural barriers. You may express it differently. It may be psychosomatic in the sense somatoform disorders in some cultures. It may be, a full-blown sort of manic episode in another culture. But whatever that is, the experience of the human being remains the same. And I also feel the other thing, there is an advancement in treatment now across globally. And as I speak, I'm pretty sure my colleagues in India are pretty much practicing TMS and ketamine and doing all the novel treatments. And there's such a growth in the mindset of understanding what psychiatry is, especially due to the pandemic.
Mhm.
I think that threw this spotlight on mental health like I had never seen before.
Yeah.
And
well, the uptick just in the identification of depressed adolescents
oh
from
my goodness,
COVID is just phenomenal.
I
And
mean,
it wasn't exactly not a problem to start with, but it's a really big problem now.
it is a huge problem. Right now, the youth are suffering. I mean, there is immense need for child psychiatrists, and there's immense need for therapists, counselors, um, people who we need for psychological evaluations. This pandemic just threw these kids under the bus.
Mhm.
Unfortunately, there was due to no fault of them, the
Mhm.
isolation that happened, and we do know right now that loneliness is one of the biggest triggers, biggest factor for suicide, for
Mhm.
increased incidences of depression, anxiety. And culturally, that's also very relevant because sometimes there can be stigma for people who are living here because of their families' conceptions and understanding about it. And we also see a lot of kids suffer because of the gender identity. And we also see that is culturally a little bit, difficult to uh, like wrap your hands around because of
Mhm.
again where the parents are from. So there's so much growth I think that needs to be done, and so many programs that I think should be there. There should be more investment in mental health. I mean, I know that that's where the government is also going, but still I do feel that it's not enough because we see
And you've
these
also got so many little charitable organizations that
so
pop
many.
up, but there's not a lot of oversight of that. So you're not sure what treatments are being offered and what therapies and
I think you
yeah.
nailed it. There's not a lot of oversight in the sense that I think right now people are just struggling through one day at a time. And I say
Mhm.
it for clinicians also, because I know a lot of clinicians who got burnt out during the pandemic. I mean, it was not possible to keep up with the trauma that they were hearing, they were absorbing, and at the same time having to kind of like maintain their semblance of like self and
Right.
doctors. So I think it was just a very difficult time for everybody. But we do see now that the incidence of depression, anxiety, rates of suicide, they're very high. And there is a need for crisis centers and counseling and kind of really looking at this in a very pragmatic way. Um, I do see the stigma slowly disappearing. So that is a huge change that I have seen
Yes.
because of the pandemic.
I mean, even my childhood in the UK in the 50s and 60s, um, people people had breakdowns.
Yeah. Yeah.
They
Yeah.
went to the hospital for a little while and nobody talked about it.
Or they
But
said that there was
if you said you were depressed, I mean, the trouble is that like the word crazy, depressed is a word that should be for a specific cause, but it tends to be I'm a little bit sad all the way to I want to throw myself off a bridge. I mean,
exactly.
it's not nuanced when we speak, but in the UK at least, if
Mhm.
you told somebody that, you were told to buck up, or you were given vitamin B12
Yes.
because that clearly was going to help. And
I mean,
it took a
sometimes
bit.
it does.
Yes, it certainly can, and there's because it's mind body, right?
It is my
But but
yeah.
but it's not one. It's not one size fits all, and it's also everything is multifactorial.
Everything, and I think that it's such a, I would say like a complex puzzle, right? There's so many factors, your social factors, your upbringing, how your resilience is, what does mental health sort of, how does it influence you?
Mhm.
What is your understanding of that? do you know how to get help? Do you know what kind of help you should get? And
But this is the problem, because we're putting the onus on the patient
right,
to
right,
figure out what kind of specialist they need.
right.
That's hard for us. So
That
yeah.
is, and I was saying it almost in a way to kind of go into my next segue, is that that onus should really shift from them to us, to clinicians who are going to step in and help them. And
Mhm.
of course, primary care, would be the first hub, because that's where
Yeah, but
the
they are
the-
also stretched very, very thin.
um,
And 7-minute clinical settings are not,
yeah,
people aren't going to tell you their deepest, darkest secrets.
of
They're
course.
gonna, I'm going to talk to you about my stomach, but I'm not going to talk to you about why.
That's why I think, right now, I think consultation models work a lot, wherein a psychiatrist might be integrated, but has sort of the oversight of how to develop the model, how to sort of
Mhm.
put in the right resources for the right patient. So I think that if, it's happening right now, there's the collaborative care models, co-located clinics, so there is sort of like the consult model, but there is this, the UW model, which was actually developed at UW, University of Washington. It's called AIMS, and the aim of AIMS is actually to make sure that there is more exposure for psychiatry in primary care, so
Mhm.
that patients can get the help where they need or where they come to receive it. A lot of the times, this is where they'll come and say they may have nausea or some sort of GI illness that is not going anywhere. And there are lots of like screening tools now that we do, which are PHQ-9s, GAD-7, the mood cue. A lot of kind of questionnaires can trigger that, okay, this might be a patient
Mhm.
who benefit from seeing a psychiatrist. But mind you, none of this is really perfect. I mean, there are
No,
so
and
many.
you're still going to run up against the patient who, we're not talking about somebody who's schizophrenic. We're talking
No,
about people who've got mood disorders
yeah,
that are going to be resistant to the first thing they're hearing, psychiatrists, they're hearing, oh,
yeah,
you're crazy, you're just crazy, go away.
yeah.
And that takes some finessing. How
That's
how would you, if you
yeah,
have a psychiatrist or a psychologist within your clinic setting,
yeah,
probably easier. Whereas if you say, I want you to go make a separate appointment to go to see
that's
this
very
person over
hard.
here. Yeah.
That is very hard. So actually, I right now I currently work in an integrated setting, at a company called Crossover, in the Microsoft location, and there are challenges right now in the sense of like how we should develop this program. But this is the basis of it, to have a psychiatrist there.
Mhm.
But I am actually soon, in September, I'm joining a startup. It's called Options MD, and I'm really going to look into people who are the exact group that you talked about. People who really don't have resources, are struggling to find help for their treatment-resistant depression.
Mhm.
Really looking into ways to innovatively help them, match them with the advanced technologies that we have right now with ketamine, TMS, or also to look into ways to do some research and see what kind of medications really might work best for a subset of population. So I'm excited. I join as the lead psychiatrist in September there.
We missed out a whole chunk of how you got from India to here. I mean, we know
We did, we
you
did.
came, presumably by plane. That's how most people get here these days. Nobody gets to have the lovely scenic sea voyage where jet lag
I don't
doesn't
know. I
happen.
mean, yeah,
But
I didn't get into like a ship for 10 days. No, it was
so,
definitely fine.
but so you came here, where were you first? Where did you
So
land?
first I was in California. Yeah, I was
Okay.
there. And then after that, when my marriage didn't work out, then I went to India for a while, but decided to study for my USMLE. So my brother at the time had migrated to Canada,
Mhm.
and I ended up staying with him sometimes. I had a cousin in New Jersey, so I was kind of like a couch surfing person.
Yeah.
But my main goal was to clear my exams, which I did. That took me about a year, but I was very lucky that I I actually got my results, and I decided to call all residencies because I thought, well, sometimes there is a post match
Opening.
happening,
Hmm.
and
Did you
luckily.
go? Were you off cycle, or do you just waited for the next?
No, no, it was actually on cycle. I was going to apply for the year after. So I had
Hmm.
my applications and ERAS applications, and I was looking at it. And someone told me that hey, it's May and I know it's kind of late and probably I'm not
Mhm.
absolutely 100% not going to get in. But there are things called, residency clearinghouses.
Mhm.
Call residencies and see if they have an opening. There is a list that's published on the internet. And that time, I mean, it was difficult to get those lists because I'm talking about 1999. But somehow I got lucky. And I was able to call a program, and that was in New York, my dream city. I always wanted to work there.
Yeah.
And
I was personally thrilled to find out where you trained.
I know
Because we
we both
trained at
have
the same hospital, decades apart, but we trained at the same hospital.
St Lukes-Roosevelt. And my God, I'm so indebted to the program, and I had a great program director, Dr. Scott Masters. And it is affiliated, as we talked about it, the University of Columbia at that point. Now it's affiliated to Icahn School of Medicine, so it's different now. But that time, I mean, I love the campus on like 112th Street, and just walking there and having my lunch there. And I think that, in New York, I got to see a cultural melting pot.
Yes.
So that also shaped my training, I think, in a great way.
Mhm.
It's really, really helped me.
How important do you think it is? Obviously, for if I was
Yeah,
seeing a psychotherapist,
yeah,
it would be very important that that person had a
yeah,
similar background to me, I think, albeit that they would have
yeah,
been born in America.
yeah.
What do you feel is important? A
What?
psychiatrist doesn't feel quite the same. Very few psychiatrists are doing standard
Correct.
therapy throughout. So.
Right. You're right. You're absolutely right. And that is, again, a lot to do with how care is being dispensed and the
Mhm.
shortage. Let's be very clear. There is a shortage of psychiatrists. Right now, we are sort of like the dying breed here because a lot of us are retiring.
Mhm.
And, there is, I know there are residencies and everything, but I think that they have projected that the shortage is going to be very acute, especially in 10 to 15 years down the road. So this is the reason why now we have to practice at the, I would say, at our top level, in the sense that we have to look at patients who are coming to us for complex psychopharm management.
Mhm.
And unfortunately, we cannot, unless we're doing private practice,
Mhm.
if we're in a community setting or even in a clinic setting, it's becoming harder and harder to have your own psychotherapy practice. Again, the world is also changing quite a lot. There is not that immense interest in the in-depth psychoanalysis. I mean, I actually trained in a psychoanalytic environment. We had supervisors, and I, again, cherish my training because I don't see that happening right now. I don't see that focus. I see a lot of it now change because of the digitalization. A lot of psychiatrists are growing into becoming digital leaders and sort of like incorporating technology through apps. And now, no, let's not even talk about artificial intelligence because that's another ball game.
Mhm.
Just see that
Oh,
everything.
if I can understand somebody speaking to me in English, if I can misunderstand them, think how well a computer's going to do.
Oh my
When
God!
you're talking about nuance, you have to listen between the words, right?
Yes,
That's
exactly. And this is actually the chapter that I have written for AI in this book that is coming out for 15 of us, 15 physicians from different specialties wrote a
Mhm.
chapter. It's going to come out in August, I believe. And I say exactly the same thing. What are the ethics of AI, the nuances? How is the robot going to understand exactly what you want me to
Mhm.
interpret? Right. And I do feel that we can only do so much. I think we can have some work standardized through AI, where you can't really replace a physician, you can't replace a psychiatrist, or
Yeah.
that human touch, the empathy. I mean, if a robot develops empathy, fine. I mean, I hope I live to see the day or not. I don't know yet. I haven't made up my mind whether I want to do that.
How
But
about the proliferation of other therapy, like myself, hypnosis, which I mean, I don't do therapy within hypnosis, but it's therapeutic hypnosis.
I
But what
you
about,
know,
family
yeah,
and marriage and family counselors, addiction
counseling,
counselors?
yeah,
Yeah, all
you
of
know,
those things fit within that
I
funnel.
definitely does fit into this. I mean, it may not be sort of like, again, and we are schooled in a certain way, right? I mean, when we did a residency in psychiatry, I wouldn't sort of like be trained in hypnosis. Maybe I should have been, but this is not an area that was from a very kind of like a structured format of how we got
Mhm.
our residency training, our fellowship training. But this is the thing that I feel like, and I know there is a little bit of this. dilemma that doctors are entering fields of coaching and all of that. But I find that why not? I mean, if there are people that are struggling, and if you, as doctors, as physicians, as therapists, as counselors, are going to touch that aspect of human life and make it better, then why not? I mean, I know that it's a bit controversial with some of my psych colleagues might say, oh, but we trained and everything, and I get that.
Right. I think that the concern, usually a legitimate concern, is somebody less qualified going to give them just enough help
Yeah,
to not really diagnose the problem and
I
just sort of
think
keep a lid on it, keep a lid on it, keep a lid on it.
I think
And
that's the
yeah,
thing. That's the thing, and it really would depend, right? And I would say that at least I would hope that if somebody sees people and feels like this is something that is beyond me,
mhm,
like this is something that really I would like a trained therapist who has gone through PhD or who has, finished their psychiatry residency and need that kind of help. And they would probably refer to that higher level of care. But right
mhm,
now, also we have, we just have such shortage that we have a lot of like mid-levels helping us out. We unless I mean, of course, they should understand the scope of how they are practicing, because that is a complete different training than what psychiatrists do, what MDs do.
mhm.
So I feel like everybody has a place in how they practice. But I do feel that if we want to build like a really integrated, ethical way of practicing, I think we should accept what our scope is, what is the limit of
Yes,
it. And we should be very clear with ourselves and sort of with the board in general, right? That this is what we can and this is what we cannot do. This is where
mm.
we need the expertise. That is my thinking. But again, I know that there is a lot of people with different kinds of pros and cons.
There tends to be a bit of competitiveness. I
And
mean,
there is a bit of like this, exactly. So I'm sort of, I follow the middle ground, but I do agree that scope of practice to define that is very important. And then
mm,
is ultimately that is do no harm to the patient, right? So I would
mhm.
operate on that. And let's say that if I was not enough qualified to be a psychiatrist or whatnot, I would probably understand that this is what I could help my patient with, but this is somewhere I feel this patient would
Right.
really
The
benefit.
problem,
So
of course, is when somebody identifies that and then they can't get the patient an appointment for X number of weeks to
I,
months,
I know
then
this
it's
is why.
agony.
This is the agony, and this is why I'm saying that there is no real answers here, and this is why we need all sorts of clinicians who are stepping up right now to help, because as I said, that psychiatrists in general, they're being stretched thin. I
Mhm.
mean, it is not a field that is sustainable anymore. A lot of my colleagues have retired, gone into small mini cash only private practices, and I think that
As a response to financial issues with the way that we're reimbursed, or as a way of controlling their own
I
burnout.
think as a way of controlling their own schedule for their own
Yeah.
happiness of life, for their own mental well-being, because as I told you, in the pandemic, like there was a lot of stress on the clinicians. So I do see clinicians branching out to doing other things also,
Mhm.
so in a way to sort of still keep in connection with the field, but in a way to balance their life towards their loved ones. So this is what I'm seeing happen a lot, and I'm seeing a lot of clinicians also become leaders, trying to have their own, as I said, digital companies or health companies, or being consultants in some. People are choosing different careers. So that being said, there is a void of how many
Mhm.
clinicians we have. So if people are stepping in whichever way, and if that's something to help people, right? I mean, right now we do live, fortunately or unfortunately, in a world of Instagram and TikToks and what have you. And I think if that platform is utilized correctly, you can use social media to really
Mhm.
influence people, to
And
teach
and
people.
some of the apps are very good, but I
Yeah,
do worry that people are self-diagnosing and following those instead of seeing somebody to get an
it,
actual diagnosis or initial help before they.
absolutely. I think these apps, these sort of like, kind of things, they help in maintenance. But
Mhm.
initially, you need to see a professional to get a good treatment plan, to understand, to have some oversight in what's happening. And then you may have the help of these apps or AI or these, VBots or chat apps or what they have to continue the maintenance. But I do feel that there is use. So that's why I say that nothing is all bad or all good. I think everything has a meaning, everything has a place in this complicated structure of what our healthcare
Right.
has become, as long as we understand the scope of that particular intervention. and we know how to sort of like raise the bar and say, okay, this is where I need you to go to
Right.
XYZ.
And just because this is about immigrant doctors, and I think, because I'm an immigrant too,
Yeah.
but I think we just need to remember how much value there is in bringing people in from different trainings. Do you think that your training in India and your practice in India affected the way other people in your program appreciate? Did you have additional stuff you were able to bring in?
I think that's such a interesting question. So my program was a melting pot itself. I
Mm-hmm.
was from India. I had another resident from Nepal. One was from Yugoslavia, I think Romania. So people were from all walks of life.
Mm-hmm.
And I felt like that melting pot itself helped each of us develop as clinicians and kind
Yes.
of each other's, I said, sounding boards.
Mm-hmm.
We used
Yeah.
to have a group, which was sort of like our kind of like a group therapy where we talked about our patients. We brought like an interesting patient and we discussed the patient. And what I really learned was the unique experiences of each of my other colleagues and how they would look at the case.
Mm-hmm.
And that made me grow so much because maybe my focus was sort of trained in one way, as we have some sort of sometimes a tunnel vision, but this broadened it. And so I would say that in India, I practiced very differently. First of all, I practiced mostly in my language because a lot of our patients were very poor and didn't speak English. And so there were different ways to kind of talk and
Mm-hmm.
this, and I learned a lot in the growth with that. Whereas in the US, I had to sort of really, change myself a bit to
But
actually
you have
understand.
so many languages available in the US too.
I do.
When
I
I
do.
when I was at St. Luke's,
Yeah.
more than 50% of the time I was using Spanish. Now that was helpful because I speak Spanish, and
Yes.
many, as we did many other residents, there were residents from Puerto
Yes.
Rico. But the people who were from Ghana, it was
Yeah.
harder for them because they
Yeah.
had, I mean, by the second year, they were pretty good Spanish too.
Yeah. Yeah, exactly. No, you're right. And I think we did like a course of medical Spanish because New York, again, for us, especially on the Harlem side, we absolutely had to
Right,
know.
but you've also got French, you've got Haitian French, which is different.
Oh, yeah.
You've got Romanian, you've
Yeah.
got you've got
Yeah.
everybody from everywhere.
Yes.
And can you speak a little bit to that when you are working with somebody who's not from your culture, but not even from your linguistic
Language.
background?
Oh,
You can
God.
get confused between English and American English for a
Completely.
while, but
Completely. Oh, my God. Tomato, right? But yes, yeah, I mean, I have to say that that time we really struggled because right now there's so many of these language services and it's really available, but we used to wait for interpreters.
yeah, but
That's why.
interpretation and translation are so different. And Google makes some
Yeah.
interesting misses. Have you ever read the subtitles to a language that you understand, but you
Yes,
watch the English and think
yes,
that's not what they said?
100%, 100%. I was just watching like a series on Netflix, which was in Punjabi, which is another format of, I don't understand the language that well, but I do know enough to know the translation in English was completely off.
Mhm.
So that does happen. And so I think that there is limitation to what happens. But, even with just the spoken words, I think the cultural relevance of those words, because it can be misinterpreted,
Mhm.
the way you say things in certain languages can be completely misinterpreted. A joke can become an insult in another language. So it was very difficult, I would say, when I had patients who didn't speak the language, who didn't speak English, or even like my little limited medical Spanish that I could understand. But they, as you explained, some people who were from Ghana or spoke a language that I was completely not familiar with. It was very, very difficult. And also when they came in a psychiatric crisis,
Yeah.
I think as a doctor, I might have shed a few tears in my, sort of like once you finish your work, and because it was hard. I mean, this person was in crisis and we just had to kind of do what we had to do. And there was nobody who could really explain to this person
I have
what was
very,
happening.
this isn't a language problem, but, and I may cut this out, but I had a client,
Mhm.
sorry, I've trained myself to say client instead of patient because now I'm just a hypnotist. But when I was still a doctor, doctoring, I was in a remote area of the country, I shan't
Yeah.
state where, and I had somebody who was having a major psychotic break. precipitated by the imminent arrival of one of her relatives for Thanksgiving. It just threw her out completely. And I had to wait for the crisis team. Thankfully, it was a very small ER. And I had the time just to sit and talk to her and like keep her okay. And what she was saying to me was very, very typical. A lot of sexual imagery, a lot of tinfoil stuff. The CIA, of course, because they're everywhere. They had implanted her with little machines.
Yeah.
And so it was what started this. I will definitely, this is too mishmashy to put in, but so I listened to this, and so I kept her steady until the crisis team got there and they could admit her to a different facility. And the betrayal on her face when she realized she was getting admitted and I wasn't just going to sit there and talk to her for 3 weeks was heartbreaking. This woman, you have to go to hospital, honey. You're in pain. I mean, she was so clearly in pain. I then went home. I used to work nights, and I flipped on the TV so I could, like, come down. And I'm listening to PBS, and it was Bill Moyers, I think. And it was all about nano machines and how you can put them into people's bodies and get feedback. And I'm like, oh my God, don't let them watch PBS. It was awful.
But it is interesting. And yeah, I mean, this is so true. I mean, there have been such stories that I can say that sometimes culture, right? TV kind of into things, and the patients, the way they'll absorb it, and then that would feed into their own psychosis that's brewing, and the way it comes out. So yeah, I have a lot of stories like that.
So we agree that immigrants are very useful to America. However, there used to be a concept called the brain drain.
Yes.
Do you ever experience any feelings of distress other than the ones sent to you by your grandparents and your parents from India? Come home. Do you ever wish that you could take what you've learned here and go back?
Always, I do, actually. I mean, I think you can't really get the country out of you. You've been in a country, you were raised there for 24 years, and I'm really proud of India from where I am, my heritage and everything. But at the same time, life does happen, and I did create a life here. For me, my brother also migrated to Canada. And so for me, we kind of became, we joke about it, we were both born in India. Now he's a Canadian and I'm a US citizen, so life took us in those paths. Luckily, we are only 4 hours away, border-wise. So, so we can see each other. But I feel like now 20 years here, I sort of feel that my life is become, more embedded here. But then again, you would say, really, because then I married a French guy. So yes, I'm married again, and I have a kid who is half French and half Indian.
So that's why my husband, I ended up staying, because I married somebody from the Dominican Republic, and the kids are American. And it's, do I go be American and Dominican in England? No, it's just easier to stay in the third culture.
That's exactly what it was. And then
I love America, but I love lots of places.
Yeah, but it's my dream, and I think it's his dream also. He's from Nice in France. So that when I retire, that's where we'll go. Once my son is college, we do what we do.
And who knows where he'll go? He may go someplace else.
He may go someplace else, but I will tell you something, talking about roots. My son is 8, and he has some, his classmates, some of them are from India. Originally, the parents are from India. And he says, well, why haven't you taken me to India? We've been to France several times. So this year
it takes a lot longer than getting to France, but yeah.
So I told him that. And I said, then the pandemic happened. Okay, I didn't do anything about it. I had plans, and you were all of 4 or 5, and now you're 8. Great. So let's go this year. So points to the stories that I am taking him. He's very excited in December to, see where I am from. Where did I go to school? What did I do? How did I grow up in India? Because kids have this concepts about parents. They were just like born as parents.
Yes, of course.
Like I did about my parents. You were just parents. You never were child.
It's like with kids when they go to kindergarten. Yeah. My teacher, she lives at the school.
Yeah.
And even sometimes a patient will, they meet you at the supermarket and they're shocked that you shop for food.
So that's a very interesting thing as a psychiatrist, because we have such.
Oh, you're not supposed to acknowledge them. Yes, very difficult.
And, it's been kind of like interesting. And I also talk about it a lot with my psych colleagues. Sometimes, I mean, I'll just see what I know they've seen me. And, if they do wave, I'll just wave back. But I do know that some patients really uh, they do not, they will feel very distorted inside if I even acknowledge them. So you really have to be very careful with that understanding of what they would feel and they wouldn't feel, but they would bring it in the session, and some would apologize and say, I just didn't know how to react. And I would say, no, no worries, like you react the way you felt comfortable. There is no right or wrong here. Of course, it's very difficult. We live in a society. We might see somebody. If you wanted to acknowledge, fair enough. And if you wanted me to acknowledge, fair enough. But it's usually just like a quick hi or quick hello, or you just move on, because
Yes.
those we definitely maintain those boundaries very, very, as we should, as we should.
Now that makes it more difficult though if you're in a very small community.
That is true.
Which has led to some issues with do you charge colleagues? Can you employ somebody to work on your house if you're the doctor? Well, if you need somebody to work on your house and the next person's 100 miles away, yes, I guess you do.
That's the thing. And see, this is the cultural phenomenon which I would like to talk about. My father, he's a general practitioner. I mean, he's retired, or I hope he's retired, because he still get calls from his patients. He's 86. Yeah, and God bless him. He's really, like as you said, the town doctor. Everybody knows him. Everybody knows of this Dr. Vaidya. So my last name is Vaidya. So he's Dr. Vaidya. And, his patients, we knew them. Some of them were fishmongers. My father was I think he practiced community medicine really the way it should be practiced. He had his own practice, but he decided the terms of it. He would charge people based on how much he thought they could afford.
Is there a national system or a provincial system or state system?
No, I mean, I'm not sure exactly how it works, because most of my doctor friends back home are in their own private practices. There is no law in India that you cannot own hospitals or practices, as there is a law in America. So it's very different. But there is insurance has started creeping in now, and there are insurance health companies coming into the, sort of like getting that part of that stake in the business. But my father, at least at that point in time, and I know my friends still who are doctors there, practice independently. They are consultants to hospitals. They get their own fees. They have their own patients. They decide their own hours. So yes, so in a way, sometimes I do look at their lives and think, I mean, it's not easy. I mean, they keep telling me it's everything looks greener on the other side also.
Of course.
But I like the autonomy that they have. I like the fact that they have that ability to, expand themselves the way they want to or not. There's not a national health system as such, but there are government hospitals. So where I did my residency in KEM, that was a government hospital. It was completely free. At a given time, I used to see 200 patients. I'm not kidding, outpatient.
Per shift?
Per shift, 200 patients. We didn't have a lot of paper charts.
Right.
Okay, let's put that EHR.
There was nowhere around.
We don't have any EMR. Okay. We literally were doing care. It was crisis care. We had patients. There used to be a line in the OPD. I still remember. And we were seeing one after the other, dispensing medications, doing what we could, sort of like we used to also have a inpatient unit. We did ECTs there. So we had to sort of prep the patients for ECTs the next day. It was very, very busy, but there was a lot of joy, because I wasn't getting encumbered by, did I tick this? Did I tick that? Did I not do this? Oh my God, like, did I not write this for the CMS measures? Which, yeah, I know I don't want to create a controversy, but I did practice in India. I would say in the 1990s, actually, I practiced from just exactly what I was supposed to do and not be encumbered by chart work.
Yeah.
That's the difference.
Yeah, that's a whole nother series to talk about that.
They don't have EHRs. Even now, my friend is not EHR typing or anything. She's doing surgeries, she's helping patients, she's delivering kids. She's doing, obviously, her documentation. It's not.
One would hope there's a document somewhere from somebody.
There is a document somewhere, but I really highly doubt that she's writing down, these click, 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 and death by 1,000 clicks. That has to go somehow. That has to be different. That I feel like doctors have lost that joy of practicing. If I had to practice in a way that I could practice in India and just really not have to bother about the amount of work that I have to do later, then maybe AI can help. Somebody can just write my notes.
Yes, maybe.
That maybe AI can help.
We'll have to figure out a way for it to be really
That
useful.
may-
As you know, I'm gonna edit everything before it goes
That's
out. But
all.
so this is, hopefully it'll be over. But the SAG-AFTRA just joined the writers' strike a couple of days ago before we're talking here.
Yes.
And their primary concern is the use of AI taking away the jobs of writers and actors, because you can now through AI, you know, make a different person, but it looks a bit like Brad Pitt, but it isn't Brad Pitt, you know. So when you consider how much emotion, and I mean real actors, not the people who just stand there and say words, but real actors, that takes up talent and a huge amount of training. It really does. There's a lot of practice goes into that. So the idea that I would get the same experience from watching a computer do it just disturbs me. They are getting better. The computers are definitely better. ChatGPT is fun to talk to. It answers you as if it's a person, but it can also say some really goofy things.
But it's really, I think that's exactly what it is. I was watching actually something, you know, there was a tech kind of thing going on in somewhere in Switzerland, and there was a robot, and a robot who's been designed that can also create human expressions. So one person asked this robot, do you think, whatever the name of the robot was, that, you know, AI is going to take over sort of humanity? And she literally gave a side eye. The way you would give a side eye, and it was creepy. It was creepy that she could understand that robot was like, she gave a sarcastic side eye, like, oh, like, how can you even ask me that question? And she gave a very sarcastic answer also. I'm like, oh my God, they are taking over the world. That scared me. I have to tell you, that creeped me out. Like,
right. That's why you say please and thank you to them in case it does. It has been really lovely talking to you, but we do have to close up, and I think I'm going to invite you back for another season to talk about some other aspect. That would be great.
Let's do this.
So, thank you so much.
Thank you so much. Thank you again for the opportunity. You have a wonderful Sunday. Bye.
Thank you for joining us at Myth Magic Medicine. If you have found this episode useful, you can apply for free CME credit through the link provided in the transcript. If you're not a medical professional, please remember, while we're physicians, we're not your physicians. So please consult with your own healthcare professional if you think something you have heard might apply to you or a loved one. Until next time, bye-bye.